Hello and good morning to everyone out there in webinar land. My name is Jeff and here is my co-colleague
Emily. Hello.
It's lovely to meet you and for you to join us for our webinar today. We'd like to start by acknowledging the traditional owners and custodians of the lands of which we're gathered here today, and their continuing connection to land, water, culture and community, and the knowledge and teachings passed down from generation to generation. We're sitting here on Turrbal and Yagara country in Yanjin in Brisbane, and we'd like to pay our respects to elders past and present here, as well as all the lands across Queensland and across Australia, indeed, if you're joining us from outside. So today's webinar is really a launch of a piece of work that we had a soft launch of last year, which was the Sex, Drugs and Worker Roles project. I think it was at the end of November, we launched a suite of e-learning and tools and resources on our website, and we're here to actually kind of talk to that piece of work in a bit more detail. So you all know me, I'm the Director of Insight, but I'll just let you introduce yourself.
Hello. Hi, everybody. Emily Buster here, Senior Public Health Officer in the BBD STI unit. And Jeff and I and the team have been working together on this project for a good year and a half. So it's great to be here and see it out in the world. So a little bit about our team. We sit within the BBD STI unit. And so there's a bit more information on the slide, but in summary, we're quite a small team. We're made up of public health officers and we sit within the Department of Health. So we're not HHS based, and would you believe it, from our name, our work is primarily concerned with sexual health and the prevention and management of STIs, and that includes workforce development. So some project background for you. I guess what underpins this largely is that we see sexual health as an important yet under-recognised aspect of people's general health and well-being. And as a lot of you would have seen in your practice, there is a bit of an overlap between sexual health and substance use. At the same time as this, we've been hearing mounting concern from the sexual health sector and in the data about the changing risk profiles of patients presenting with STIs. And this is notably patients having a history of alcohol and drug use, or mental ill health comorbidities, and other complex social determinants. And now the data is showing that this association is particularly the case for syphilis, including syphilis in pregnancy. Syphilis is a very big growing public health concern because rates have been rapidly increasing over the last several years, but we'll go into more detail about that later. At the same time as all this going on in the sexual health world, we've been hearing from the alcohol and other drug sector that there is a growing interest in better responding to the sexual health needs of clients. And so we did a bit of digging around and talked to a lot of services, and it came to light that there really wasn't much existing training, tools and resources specific to that intersectionality between alcohol and other drugs and sexual health, nor that was seen as tailored to the workforce. So we got into it. We started by doing a literature review, and then, as some of you may have participated in this, we sent out a scoping questionnaire for the Queensland alcohol and other drug workforce and got some really interesting responses. And here's some key themes that workers themselves were observing: the strong association between substance use and risky sexual behaviour, that there was a limited knowledge about sexual health for themselves, and that they observed this limited knowledge also in clients. And as we mentioned before, that there really is a lack of tools and resources to help facilitate a discussion, let alone an intervention with the client. I'm not sure if Sean is on today, but QNADA came on board and have been a fantastic partner in this project. They hosted a really great forum with some panelists, great discussions, of which interestingly came out that workers were talking about that sometimes even just broaching the topic with the client about sexual health is a hurdle in and of itself, let alone the complex or detailed information. People talked about that sexual health really should be seen as a core part of business for AD services, because really it's about responding holistically. And we had some great services such as Quinn talk about that collaborative relationships with sexual health care services are really important if the pathway is to be as easy as possible for clients getting the care they need. Next step was establishing the project advisory group, which you can see the list of people that are involved there who helped bring it all together. And so that brought us to, next one.
Okay.
Hey, there we go. That brought us to the challenge really that we had, which was how through developing some learning materials can we help the workforce to understand and tailor a sexual health intervention based on functional understanding of how sex and drugs work together for that individual person, and really developing something that can teach people the tricks of the trade when it comes to talking or asking about sexual health, especially during the comprehensive alcohol and other drug assessment.
Excellent. Thus, the Sex, Drugs and Worker Roles project was born, and credit must be given to Sean Popovich for coming up with that clever title for the project, which we ran with. And the aim of that kind of initiative was really to develop a range of high-quality sexual health educational products and resources designed to equip Queensland's government and non-government alcohol, drug and mental health workforce with the knowledge, skills and confidence to undertake the basic sexual health assessment, brief intervention and appropriate supportive referral with clients and patients. So that's it in a nutshell. And what was launched and what is available now. So if you go to our website and click on toolkits, it's the first kind of featured toolkit on the top left-hand side is the Sex and Drugs Toolkit. You'll land there and you'll find these 3 e-learning modules, which are available. They're all self-paced. You can pick them up, go halfway through, and if you leave, come back and pick up from where you left off. They're quite brief, really, and it features a whole bunch of videos, which are embedded in the learning, but also available in the toolkit. There's 3, but there's about 6 or more of our own that we've developed and other kind of great resources that are related. And also we developed a bunch of downloadable resources that are really handy to have at hand during a session or an assessment with a client, which kind of can help you with quick reference guides, tools, and even tip sheets for talking about sexual health. So we're going to go through some of it now, like a bit of a highlights reel, effectively, of the package that we developed. And we've got a bit of a quiz. And so what we're going to do is we're going to launch a little poll, and I'll just jump back so you don't see the answers. And our first poll here, what we'd like you to do is quickly answer these 2 questions, and then we'll see how you go in terms of a response to these 2. Hopefully you can see that on your screens now. So click on the quizzes. The first question is, combining sex with substances can, and it's multiple choice. So choose which of the following answers you believe are correct between enhanced sensitivity and make sex more pleasurable, inhibit a person's ability to consent, make it difficult to feel aroused, enhance the quality of a relationship, lead to sexual experiences that may be regretted, or help with feelings less nervous about having sex. And question number 2 is primarily about the prevention and treatment. Which of those do you think is your correct answer? I can see you putting your responses in now between those 4. Is it primarily about the prevention and treatment of STIs? Is it a state of physical, emotional, mental, and social well-being? Is it primarily concerned with sexual intercourse, or is it about the physical health of people who are sexually active? So yes. So I'll just give you a few more seconds while you select the answers that you think are correct. Remember, it's multiple choice, so you can select as many as you like, except for question 2, which is single choice.
Giving it away.
I know. Alrighty. We've got about 60% of you have answered.
Fantastic.
When we hit 70%, we might just reveal the answers to keep it moving. Oh, we've hit 70%. Oh.
73.
Alrighty.
Climbing up.
I might just end the poll there and reveal the answers. All right, so hopefully you can see that on your screen now, the answers. So the answers to question 1 was actually, and we didn't put this as an answer, all of the above. So really, we're aware that the interaction between sex and substances is quite dynamic and multifaceted. And it could be, there's a whole bunch of kind of factors which have both positive kind of ends to it or not so positive kind of aspects to it on the same kind of continuum. So that's what makes it quite a dynamic, interesting kind of concept to work with clients about. And yeah, when we talk about sexual health, there is a bit of a perception that's primarily around STIs, but really the world of sexual health is far more open and broader kind of conceptualization, which is around well-being effectively, because we know how much people's sexuality, people's identity, people's practices, of which STIs is obviously a part of that, all contributes to somebody's sense of physical, emotional, mental, and social well-being. So that is really the main answer that we were looking for that one was option number 2. Do you want to add anything to that?
I was going to say well done for most people getting option number 2, and that it's not actually just about if you're sexually active. Sexual health is far broader than that, and it's not just about sexual intercourse as well. So
yes, excellent. Thank you. We've got a few more of those coming in, so keep your mouses ready. All right. So just move on. There were our questions, there were our answers there. So I'll keep going a bit. Sure. So this first module that we launched talks about this concept of sexual health identity, human identity, and this kind of interaction between sex and drugs, effectively, including barriers and stigma. Because as we mentioned earlier, the interaction is complex, but for most people result in no or negligible harm. But obviously in our world, there are harms, and that's why we're here and why clients are accessing our services. And the EMCDDA releases kind of report that kind of explored it, which we drew upon when we developed this content, which looked at 4 contexts where the interactions between sex and drugs can cause harms. And the first context was this one, the individuals who are intoxicated. And this is what the one most people think of automatically, is that through that act of intoxication or impairment, that leads them to engaging in sexual activities that they never intended, and that can be consensual or non-consensual. But crucially, the person did not intend to engage in sexual activity when they used the substance. Instead, sex only occurred or happened in the way it happened because the person was intoxicated. And so this is the classic one of someone engaging in unprotected and/or regretted sex or sexual assault following substance intoxication. So that's the first model. The second model, and this is kind of comes into our remit a lot more as alcohol drug practitioners, is that people with established harmful independent substance use engage in activities that either directly or indirectly puts their sexual health at risk. And we know that some of our more vulnerable client cohorts, may resort to having to have sex for favours, to fund drug use or for sex for survival. And some of this can lead to, STIs and other kind of sexual, assaults or kind of, there's a vulnerability around that puts them at additional risk. The third context is where psychoactive substances are used immediately before or during sex with a specific intention of enhancing the experience. So it's facilitating, the drug use is facilitating the desired sexual experience. And, obviously with methamphetamine and MDMA, the chemsex kind of phenomenon has emerged, also around GHB or GBL and amyl nitrate and or nitrous oxide in the context of chemsex parties. And we also know that sometimes there's some particularly complex and nuanced kind of risks, particularly when people might consume, say, stimulants to enhance a night, but that may cause some sexual arousal problems or erectile problems. So you might take some Viagra or Cialis to offset that, but then you might also take GHB or amyl nitrate to enhance the sexual experience. And some of those combinations are particularly high risk, particularly that between, the Viagra or Cialis and amyl nitrate poppers, because it can rapidly drop blood pressure and people can pass out. So we know that that's a particular risk in certain cohorts. But also accidental swallowing of amyl nitrate being passed around in particular, settings or parties, people thinking it might be GHB or GBL, but actually swallowing amyl, which is an inhalant, and at that level requires hospitalization and can cause death. So that's another kind of interaction between sex and drugs. And then lastly, it's kind of looking at when substances are used to cope with the emotional distress associated with a sexual-related health problem, such as a new diagnosis or debilitating symptoms or associated stigma. So maybe using substances to cope with, say, sexual problems such as erectile dysfunction or painful sex, or to help cope following a new STI or BDV diagnosis. So that's the relationship. So yeah, so it's, as you can see, there's lots of different ways that sex and drugs interact, and it's important to think about that with the different types of clients or patients that you work with, because it's not always going to be the same, and some of the motivations or the functional reasons are so different, and it requires a response that's nuanced and related to that functional reason for the substance use and the sex. Here's an example from the module. Freya, a 40-year-old cis woman who identifies as heterosexual, pronouns are she and her. She lives in a regional town with a long-term partner, is on the opioid dependence treatment, but is on long-acting injection, buprenorphine, but smokes methamphetamine every few days. Discloses pelvic pain for the last few weeks, and when asked about sexual practices, said she'd been using more meth than usual and had been having unprotected vaginal and anal sex with other men for money. So more along the lines of that context two, that model two that we talked about earlier. So in the context of Freya, some of the particular risks that Freya might be vulnerable to are obviously risks of BBVs and STI transmission through the unprotected sex, that the pelvic pain could be symptomatic of pelvic inflammatory disease, which could be a result from an untested STI, largely chlamydia or gonorrhea. There's a risk of unintended pregnancy, and if syphilis is present, a risk of congenital syphilis, which Emily will talk about in a few moments. And also that sex for favours or sex work may increase the risk of non-consensual sex. So that's one example of many that you can find in the modules. So yeah, and obviously stigma and discrimination. We're very well aware of the impact of stigma and discrimination in the AOD world. It's also very present and prevalent in the STI or sexual health world as well. So if you combine these two factors, you can see the potentially compounding effect of stigma and discrimination, and individuals who seek specific kinds of sexual and reproductive health care, HIV, STIs, abortion, contraception, sexual dysfunction, or transgender health are particularly affected. So we just need to be super conscious of that, and particularly if these clients are accessing our AOD services and building trust with us, because a lot of our clients and patients don't feel that trust with their GPs or other health professionals or their therapists or counsellors or family or friends, that we should, in that position of kind of trust, don't feel shy to ask about STIs, because they're more likely to disclose to us and maybe their practices or their concerns that they might not disclose to someone else, and we can start to address some of that. So let's introduce our friends. Do you want to talk about this video?
Sure. So this, as we talked about in the beginning of the module, we go into human sexual identity, because there's a lot of you may or may not, pick up on clients that walk in the room. Human sexual identity is multifaceted, as Sam will talk about. It includes sex, gender, sexual expression, and attraction. And so it's important for everybody, not just within a work context, to be aware of this when working with a client, because how you respond and interact with a client on these things will have a direct influence on how safe they feel to have these conversations with you and how that rapport building goes. So
So sexual health is way broader than just STIs and STI management. So when we're looking at people in their entirety, I think it's important that we actually look at all the facets that make people, I suppose, sexual human beings, I suppose. I like to use this model here because I think it really shows you the different diversity and what makes people humans and how they express themselves. So first of all, we've got sex, and that's often when people are born, that is determined by the medical officers when somebody's born as to whether they're male, female, or intersex. And this decision is very much based on genitalia and also chromosomes, but it doesn't necessarily explain people's gender. And you can move on to the second one here, and it talks about their gender identity. So how people describe themselves, and again, it really is up to that individual as to how they express their gender. And their gender expression could be whether they portray themselves as either being masculine, feminine, or also gender neutral. Sexual orientation is basically who people are attracted to. So really, who turns you on? So with that in mind, who are you? So how do you identify your sex, your gender identity, your gender expression, and your sexual orientation? So basically, don't put people in boxes. I don't think you can make assumptions about people and their lifestyle, their sexual orientation. Ask them about it. Make sure that you're not putting people in boxes and making sure that your ideas or your first impressions are actually going to cloud your judgment.
Oh, okay. So we're on to a quiz. That's Simon Doyle Adams from Cairns Sexual Health, who partnered with us very closely in developing a whole bunch of videos on this topic. And that's kind of, encapsulates some of Module 1. We're going to look at Module 2, and this is what it's about, but we've got a little bit of a quiz here, which we're going to launch. So this one has got 4 questions, which you can answer in your time, which I'm going to launch now. And I might throw over to Emily to run through these.
Sure, because this is a bit more STI related. So first one, select the ways an STI can be transmitted. Is it through unprotected oral sex, sharing food from a toilet seat, by mosquito bite, unprotected vaginal or anal sex, mother to baby during childbirth, or kissing? Question 2.
That one's multiple choice. You can choose more than one answer for that one.
These are all multiple choice. And we're being a bit tricky with all of the above and none of the above. Too easy otherwise. So chlamydia and gonorrhea can be easily treated if diagnosed early, often don't show symptoms, can be seen in someone by just looking at their genitals for a discharge or sore, can only be caught once, or are a problem only for females. And the third question, you only need to get a checkup if you have some sort of symptoms, true or false. And then one about syphilis. What are some of the risks if a mother contracts syphilis in her pregnancy and isn't treated? Miscarriage, stillbirth, preterm birth, fetal death, or damage to the baby's nervous system and organs. So a bit more time for this coming in.
They're very quick off the buzzer. Well done.
Love it.
Yes. 30% of you have already finished all of the questions. I'll just quickly to Sarah as well. Amyl nitrate and nitrous oxide are both inhalants, but they're different. Amyl nitrate in particular is a muscle relaxant and drops the blood pressure quite significantly. So yes. Nitrous oxide is named, the common one used for whipped cream canisters, whereas amyl nitrates are usually in a little bottle that the vapor just evaporates like salt and sniff it through them. Poppers is what they're often referred to.
Okay, 58%. We'll wait a bit more. Here we go, pouring in. 70% again.
Yeah, when we get to 70%. Ooh, I think Ben's identified a bit of an issue with question 4, which we'll get to.
That's all right.
Yes.
We'll just talk our way through it.
Yes.
All right.
Okay, I'll end that. We'll share the results. Thanks, everyone. All right.
All right. So fantastic. Most of you got that right, because STIs are transmitted through unprotected sexual activity. So this includes oral sex, anal sex, vaginal sex, and some can also be spread through close sexual contact, sharing sex toys, rubbing genitals, that sort of thing. Kissing, though, isn't considered a risky activity for spreading STIs. Neither is sharing food, toilet seats, as you know, the great myth out there, by mosquito bite. But some STIs can be transmitted from mum to bub, either in utero or during birth, if the infection isn't treated.
Are cold sores considered an STI in terms of kissing?
For herpes, yes, but herpes is a bit of a tricky one, because it's you can only really test for herpes if you have an open sore, and the treatment for herpes is an antiviral, so it's a bit more nuanced, that one. But in terms of HIV, chlamydia, gonorrhea, trichomoniasis, syphilis. Kissing, it's a very low likelihood because you kind of need to have like an open part of the body, you know, touching another open part of the body, and it's similar to a toilet seat. Okay, chlamydia and gonorrhea can only be treated if diagnosed early and don't show symptoms, because both of them are frequently asymptomatic. And this is actually the case for a lot of STIs. So even if a person doesn't experience symptoms, crucially, the infection can still be passed on to others. And even if they don't have symptoms straight away, it can still cause damage to a person's body. You can get, nobody clicked only female, that's fantastic, because regardless of your body parts, you can get an STI, you can get chlamydia or gonorrhea. And they can be caught more than once, and the more times you have an infection, the greater the health risks are. This relates very well to question number 3, that you don't need symptoms to have a sexual health test. As we mentioned before, a lot of STIs are asymptomatic, but this does not mean you're out of the woods. So this is where testing is really important, because without testing, it's hard to know if you have an infection, hard to know if you need treatment. Syphilis, all of the above, all of them are correct. Syphilis is, as we said, a growing public health concern, and when it's passed on to baby, it can be really, really dangerous, and all of these things are a possibility. So
we're very sorry that was accidentally entered as a single choice when it was supposed to be a multiple choice question. So hence all of the answers for the last one.
Yes, all the answers for the last one. Yeah. Okay.
So our apologies for that. There's a little technical error, but yes, all of those answers are correct.
Right.
Yes.
So module 2, this is where we go into more depth about these sorts of questions. We're going into STIs as a particular sexual health risk. As we mentioned before, it's not the only thing about sexual health, but it is a particular risk and something we see a lot in our work here. So we go into prevention, symptoms, look at testing, treatment options, and also look at that interplay between risk perception, risk behaviour, and harm reduction. So crucially though, we've recognised, and this came out of the panel, out of the forum and the scoping exercise, that it's not always within the scope of all workers to do, say, comprehensive sexual health assessment, testing, treatment, contact tracing. But regardless, it usually is within a worker's role in the service they're in to support a client with their general health. And this is where we see sexual health as a part of that. And in this way, this module is not very specialised, but it is designed to give workers a general overview of sexual health and to familiarise themselves with the basics. And this is really so that a worker can know what to look out for and can be better positioned to provide general information, support, referral, resources, that sort of thing. So as an example, it might be explaining the role of testing, because symptoms usually, don't present straight away, or that most STIs can be managed, or that even what happens during a sexual health check, and that the clinician will ask about drug use but will not be reporting it, and to explain the reasons they may ask. So even if it's just simple provision of this information, it can be really useful to a client who, may not be aware of some of these things, or just might have some concerns and some issues with actually getting sexual health care. As Jeff mentioned, we developed some resources to help with this. So this is an example of one that captures, it's like a quick cheat sheet for the major STIs in Brisbane, just in Brisbane, in Australia. So here we're looking at modes of transmission, signs and symptoms, complications, treatment, but crucially at the end, risk reduction, which plays into some of the strategies you might be able to work through with a client. So condom wearing, screening, for some it might be new injecting equipment, etc. So this is all in the toolkit. It's super useful. Print it out, chuck it on your wall, maybe even go through it with clients depending on the situation. And now the great mimicker. So syphilis is an STI that's been around for many years, and recently over the last 5 years we've seen a dramatic increase in syphilis cases in Queensland and Australia-wide.
One of the main concerns about syphilis is that a large proportion of people who have an infection won't show any symptoms. And if they do happen to have symptoms, they can often be very similar to other health concerns. For example, one of the first signs of a syphilis infection is a painless sore, or what's sometimes called a chancre, and it's usually found around the genital area, mouth or throat. And these can very easily be mistaken for a different infection, and they'll also usually heal and disappear after a few weeks without treatment. Chancres aren't the only symptom of syphilis, there's plenty of others too, but they depend on the stage of the infection. Crucially, it's important for workers to know that even though symptoms like these sores may come and go, if syphilis isn't treated, the infection still remains in the body. And this means that it can be passed on to others, but also that it can still cause health problems for the person. For this reason, without testing, syphilis can be quite hard to identify, and it's very common that many people are not aware that there may be a problem. For example, they might not know that they have an infection, or that a person or people they have sex with has an infection, and therefore that they're at risk of getting syphilis. And they also may just not know the importance of getting testing, in that syphilis is often asymptomatic. In the long term, if a syphilis infection is not treated, it can affect different parts of the body and cause problems with the nerves, the brain, and large vessels near the heart. Here in Queensland, the largest concern we've observed over the last 5 years is the dramatic increase in infectious syphilis in heterosexual people at childbearing age, and our particular concern is the rising cases in women. And this is because if a woman is pregnant and has untreated syphilis, there's a high chance of it being passed on to her baby during the pregnancy. This is called congenital syphilis, and it can be very dangerous for the baby. It can lead to miscarriage, preterm birth, and sometimes the baby may be born stillborn. The baby can also become critically unwell after it is born if the infection is not picked up and treated. And there's also the risk of longer-term health consequences from organ, brain, and nerve damage to the baby. We're also seeing evidence that many of the infectious syphilis cases in Queensland are in people from more vulnerable and disadvantaged populations. And this in part comes down to competing priorities and also barriers in accessing healthcare. If people have a lot of other concerns in their life, for example, with their health or their relationships or immediate needs like housing and money, then going to get STI testing or treatment after they've been diagnosed may not be as high a priority. However, the tricky part is that this can cause longer delays with somebody getting the care and treatment they need if they have an infection. And this is where an AOD worker is an excellent place to provide support. They may have already built a rapport with that person. They'll probably, compared to many other care professionals, be more aware of a client's situation and its complexities. They are also in a better position to understand the barriers a client may face in getting sexual health care and treatment, and therefore they're in a great position to support a client in working through them. The good news is that syphilis is treatable if somebody can get to a health service. And we do know that most people in life want to do what's best for their health, and they also want to do what's best for others. They sometimes just need that extra support, and this is where an AOD worker can be really effective.
There you go, you heard it first.
Heard it first from me.
Yes. We're also, I don't know if you saw this, but Norman Swan's health report this week was focused on
yes,
syphilis, and so it's an issue that's obviously experienced right across the
And
country.
if our Norman Swan is talking about it, then it must be a big deal.
Yes.
So yeah, good to focus on syphilis. It is the STI concern, and I see we've got a question from May about HPV. And look, HPV, it's a really good point you mentioned there. A lot of HPV is picked up through regular cervical screening and through immunisation. And when it comes to males, I believe that males are being vaccinated in schools as well. But this is a great example of a really effective public health intervention, both in the screening and the immunisation, because there has been a huge decrease in cervical cancer from HPV. So it's similar to herpes in that, not similar to herpes, but like, yeah, it's one of the more success stories of STIs, put it that way. So it's not a big focus in our e-learning, where we're looking at ones that are still, we're still trying to get on top of Is syphilis detectable from a urine test? Syphilis needs serology, so it needs blood to be taken, but there are point-of-care tests for syphilis that are offered from some services. Great question, Sarah. So further on in the module, we revisit some of the foundational practice skills that a lot of people working in this space will already be familiar with, including taking a trauma-informed framework, taking a harm reduction approach. And as you can see here, we use a series of case studies to demonstrate really how people can use the existing skills that they have in a sexual health context. Because a lot of fit workers have the skills necessary already. It's about helping make the connection with how they can be reapplied. And just a quick note, as we said, this is quite general information, but for those of you wanting to do the e-learning that are nurses that are able to do testing and treatment and whatnot, the toolkit does contain guidelines, testing tools, and those sorts of resources which will help you in that regard as well, and other more specialised training. We keep sharing the answers.
Right. We'll launch our third and final quiz for this webinar. So get your mouses and keyboards ready. So yeah, I'll let you run through this.
Great. So question 1, you need to be 18 years or older to be tested and treated for an STI, single choice. During a sexual health checkup, a clinician will ask about drug use, won't test for drugs in a person's system, will report drug use if it's disclosed, will make a risk assessment based on information about the person's drug use, won't ask about drug use at all. Question 3.
That's multiple choice.
And that's multiple choice, yes. Question 3, what are the main ways someone can reduce the risk of contracting HIV? Is it maintaining an undetectable viral load? So that is taking your HIV medication to where you still have the virus, but it's not detectable. So you have a very, very low viral load. Taking PrEP, using condoms, taking PEP, which PrEP and PEP, if you think medication before having an interaction that might transmit HIV to prevent that, taking PEP, taking afterwards if you've had an exposure, or using clean injecting equipment. New injecting equipment.
And question 4.
Question 4, sorry. I didn't scroll far enough. Okay, other ways of preventing STIs: avoiding penetrative sex and just doing oral, wearing 2 condoms, the withdrawal method, being on the contraceptive pill, all of the above, none of the above.
Thank you for your responses as they're trickling through. Ooh. We've done the same thing there.
No, I think we're not.
Good choice. Oh, there you go.
All right, 65%, going well.
All right, we'll give you another 15 seconds to put your answers in. Great.
Right.
We hit our 70%, so we'll share the poll. Thank you very much.
Okay, so question 1, you do not need to be over 18 years to have a test for STIs, because there's no age limit, and at age 15 you have your own Medicare card, so you can book and attend appointments on your own. And there's usually concessions for young people for testing to be free, which is great. During sexual health checks, so able to share the correct answers. This might help them talking through it. There we go.
Yeah.
So a clinician will ask about drug use, and the reason is that how, depending on what drugs people are using, that's going to inform the risk assessment. It's going to inform what to test for, because obviously the mode of transmission differs depending on the STI. They won't test for the drugs though, and they will not disclose it will not report it if a client discloses it. Okay, question 3, the main ways of reducing HIV. Well done, everybody, all of the above. And finally, this is a bit of a myth-busting one because these things come up a lot in the STI world. Other ways of preventing STIs are none of the above. Double the protection, double the condom does not equal double the protection. And STIs can also be spread through anal or oral sex. So, yeah, some key messages in there.
Excellent. Well done, everyone. Smart little audience we have today, as usual.
Okay, this brings us on to module 3, and this is where we're tying it all together. And we're doing this by looking at a framework that people can use to undertake a basic sexual health intervention. So this includes identifying appropriate scenarios in which to raise the topic, looking at how to initiate a conversation, and also identifying when it's necessary to do a referral. Resources. We've done some more to help with this one. So one of these is an organisational checklist. And this gives some guidance on how to create an organisational context that is conducive to this sort of work, that helps a client feel safe, that helps staff feel comfortable as well. So check that one out. It's really useful. And we also have a referral tool. This is 2-paged. Acts as a quick guide, but also as a quick directory for some of the major sexual health providers or, online websites in Queensland.
We'd like to thank our friends at New South Wales STIPU for some assistance with these resources
yes,
as well.
Yes, definitely. And it's not pictured here, but later on we have the tool, the framework tool. So one side is a quick reference to how to follow the tool, and the other side has some of the basic sexual health messages that we're hoping people can pick up through the training. And that can be a quick prompt for when, working with a client. So the framework itself, it's designed as something to help guide a conversation with a client about sexual health and to assist you in helping understand their needs, their concerns, their thoughts, and in this way, being able to be in a better position to give support. So step 1, of course, is asking permission. It shows respect, helps someone feel safe. It's really important in building rapport. Part 2 is opening the conversation by building on what the client already knows and listening to them, letting them co-direct the conversation. And a lot of you will be familiar with how to, the kind of finer skills and how to, do that part. Information, of course, is acknowledging what they already know because, some people do have some sexual health knowledge out there. It's a chance to correct misconceptions, offer information that's relevant based on that listening process, and obviously mutual understanding is really important. Step 4 is resources, where you can direct them to the information, resource and support for their needs, and if necessary, a referral, preferably a warm referral to a service that's right for them. And that's where the directory hopefully will come in handy because it's got information there about LGBTIQ communities and services that are appropriate, that are known to be safe spaces for people that engage in sex work, things like that. We finished the module with a demonstration video because I think it's important for workers to get a bit of an idea of how it can be adapted, and it is designed to be loose enough to where it can be adapted and depending on the context. So in there are some practice tips and
demonstrating ways to raise a topic, ask the question, clarify meetings. So just a little bit of an example
Exactly.
for people who might want to see it in action.
Mm-hmm.
Okay, so they're the modules. Thank you for that overview, Emily, and for everyone. I'd also like to acknowledge Ben Walters, who I know is here at the moment, who really helped us with a lot of the writing, and the multimedia teams who did a lot of the filming and editing. So thank you for everyone. We'd like to just invite our friend Jo De Battista, who I'm going to bring up. Jo, if you're ready and waiting, what I'm going to do is just promote you so that you can be seen by everyone. And you might want to have a quick overview for us. To you go, Jo. So if you accept that little button, Jo, you might want to jump on and talk to us briefly about your work. Yeah. Hello,
Hey.
Jo. How you going?
Hello, London. Hi,
Thanks for
Jim.
coming on, Jo.
Hi, Emily.
It's
How
been
are
great.
you?
What we wanted to do, and thank you for your invitation, is just tell us a little bit about your role, what you do, because we want to show to our lovely viewers and guests some of the examples of where this intersection between sex and drugs hits the road in a practical sense, and some of the work that your unit does. So thanks, Joe. Give us a little rundown of your world.
Oh, thanks so much, Jeff. Thanks so much, Emily. Yeah, look, hi there, everybody. My name's Joe. I'm the Sexual Health and Bloodborne Virus Coordinator for the Metro North HHS, and I'm actually based here at the Public Health Unit here at Windsor. And I guess my role, it's whenever we use the title coordinator in a role, it all becomes very kind of vague and nebulous. But essentially, I would probably define my role as a person that goes around trying to identify the issues, the needs, the gaps within the community in relation to service provision for sexual health. And so what I try to do is work with various organizations, with public health services, with the government, with professional bodies, with the community, in trying to find ways to address those needs, issues, and gaps. So I'm like an extra pair of hands to help with trying to develop new strategies. And certainly in this area of alcohol and drug, as Emily pointed out, over the last couple of years, particularly with seeing that rise in syphilis cases amongst young women and that overlap that we've seen with these women, with mental ill health, with alcohol and drug use and other adverse social determinants, it really has rung alarm bells for us. But I really want to point out that there is a hugely long history of sexual health and alcohol and drug working together, going right back to the origins of the HIV epidemic, and going back to the 80s, when we look at the work of our needle exchange programs, our methadone clinics, they were right at the forefront in terms of HIV prevention. So there is a huge body of work in regards to bloodborne viruses. But what over the years we've been really trying to do is, if we're really wanting to do, for example, effective HIV prevention, we recognized we needed to broaden right out to include all the other STIs. And so as a result, in terms of working with injecting drug users, and in terms of bloodborne virus prevention, HIV prevention, there was a real recognition we had to expand and look at sexual health holistically. And by the same token, when we look at the work of sexual health clinics, very quickly they realized, we can't be separate from drug and alcohol. We really have to take into account drug and alcohol in our risk assessments. So over the years, there's been a number of really great initiatives, and I can only really think of the ones that in Metro North, I really, for example, in no particular order, want to salute what Quinn have done, particularly over the last year, incorporating point of care testing for syphilis within their needle exchange programs and within their outreach programs. And that's been great. And so as part of their Hep C testing outreach, they've also looked at, okay, we can't just look at Hep C in isolation. Certainly they're looking at HIV and Hep B, but also there's been a recognition we need to now add syphilis as a point of care test, and then leaving open the possibility for also including chlamydia and gonorrhea rapid testing through the Gen Expert assay. And that's a pretty important point too, because a lot of alcohol and drug services have been very involved in Hep C testing, and that's been wonderful. But what we've also noticed is, again, a very strong overlap between Hep C and syphilis as well, because the risk factors for Hep C have also been some of those risk factors for syphilis. So there's been quite a bit of work and great collaboration from a lot of the organizations that have been focusing on Hep C to also include syphilis. And I guess it kind of makes sense, because if you're collecting a blood to test for Hep C, which will also include probably a test for Hep B and HIV as part of the baseline, so we're always thinking about BBVs, bloodborne viruses, well, why not add a syphilis test to that blood test? Let's start the conversation more about BBPs, bloodborne pathogens, rather than just bloodborne viruses, because syphilis often can fall between the cracks, because it can't be tested by urine like chlamydia and gonorrhea. So we have a lot of urine-based testing for chlamydia and gonorrhea because it's simple, it's quick, we can do it in the community. We forget about syphilis. And at the same token, we got bloods being collected for bloodborne viruses, HIV, Hep B, Hep C, but we forget about syphilis. So let's see if we can kind of bring them together. But certainly, in terms of other programs, Munya, for example, the Salvation Army's rehab unit at Munya at Red Hill. For many years, we were doing sexual health education with the male and female residents there. And Munya had a great referral pathway, a link with the local GP practice and also with the sexual health clinic. So Alcohol and Drug Services also developing really great referral networks. For many years ago, for example, the Sexual Health Clinic at Biella had developed really quick referral pathways with the Alcohol and Drug Service at Biella so that clients could quickly be referred from sexual health to alcohol and drug and vice versa. So looking at what are your partner organizations and what kind of referral pathways you could develop. And also, very much education as well. I know, for example, Drug Arm for many years with their outreach, their mosh pit van, their outreach van, had worked very closely with the old sex worker organization called Squizzy and the Sexual Health Service. Squizzy is now Respect. But they had sort of done a collaboration with their outreach van for many years where they were doing outreach to sex workers, offering sexual health checks on the van, while Drug Arm volunteers were addressing those other social determinants, whether it's housing or drug and alcohol use or food. And even more recently, February was their special sexual health education awareness month because it coincided with Valentine's Day, and they did some great education with their staff, really just trying to promote that awareness about sexual health. So there's been really quite a number of initiatives over the years. Alcohol and drugs, sexual health, very, very closely related as partners in this. So really just want to, a big salute to the great work that's been done in this area.
Yes. Thanks, Joe, for that overview of the whole system. And I think it's the key message there is if your AOD service doesn't have great sexual health capacity, start just by upskilling your frontline staff, your counsellors, etc., in some of the modules here. Build then the relationships with the SDI, or sexual health service providers. And as that grows, you may find that you have the capacity to implement that more within your own service, such as the BIM model, but you don't have to go straight to the point of care testing inside. You can build up and grow as your relationship with those kind of co-providers in your local area grows, and it's treated as a continuum that you can work on.
Yes, yeah. Certainly, Jeff. And I just remembered too, on Metro South side, for example, some of the adolescent or the youth-based alcohol and drug services had some really good collaboration with the PA Sexual Health Service, where staff from the PA Sexual Health would go out and do some outreach to those centres, doing education and also offering screening on the spot. So there's been a long history of that in other places as well. So it's about developing those collaborations and partnerships with your local sexual health service.
Yep. Mm-hmm. Thank you, Joe. Really appreciate your time and your perspectives and your hard work in the Metro North area for chiming in to give us those great local practice examples. Thanks a lot.
Thank you very much, everyone.
Okay. Cool. I'll leave you there. So just to wrap up now, check out the toolkit. It's there. There's the link. Go in and play around with it, and please share it with your colleagues and friends. And we just want to thank all of the people that were involved in the project. So big shout out to Kianara and to Sean for his involvement, particularly in the beginning of framing up the whole project and review of the modules. Our friends up in Cairns Sexual Health Service, who we went and did a lot of filming up there. Quinn, who've been a big partner in this project as well, and for their comments and review. A number of staff from Metro North Mental Health Alcohol and Drug Service, the Queensland Syphilis Surveillance Service, and the Metro North Public Health Unit. And Asham, our friends at Asham, who provided a lot of support as well. Thanks to the New South Wales SDI Program Unit, STIPU. There was a number of clients and consumers who were involved and contributed their perspectives, including on film and via recording. So thank you to those guys. And lastly, to the Communicable Diseases branch within Queensland Health, who are obviously behind the whole project and funded it, including yourself, Emily.
And thank you to Insight as well for making it all happen.
So yes, and to our colleague Ben, who we mentioned earlier, and our multimedia teams. So yes, so go forth and share the good news. Thanks for joining us today for launching the official launch of Sex and Drugs. Our next week's webinar is by Karen Monash from the Queensland Human Rights Commission, talking about the Human Rights Act in Queensland, same time next week. And we've got a quick survey that's in the chat that Niall's just dropped there. If you wouldn't mind letting us know your feedback, that would be great. Thank you. And there's a link to the toolkit there as well. Thanks for your comments and questions as well. Sorry, there's a few glitches with the quizzes. Thank you. We appreciate that sometimes happens. Sorry, Jeremy.
So the one about 2 condoms, I've just seen a question there. I believe the issue is the friction on the 2 condoms, which can sometimes lead to breakage. So 1 condom is also sufficient, and 2 doesn't actually mean double protection.
HPV and throat cancers?
That's not really probably something I can comment on off the cusp, actually. Sorry about that. Yeah, not something top of mind.
Thanks, Brendan. Yeah, it makes sense to combine the syphilis and hep C testing.
Thank you, Joe, answering that question about Hume's diagnostics. Yeah. Fantastic.
Excellent. I think that's it. We appreciate your time. Have a great week or rest of the week, everyone, and hopefully we see you next week. Cheers and bye for now.
Bye.